right, well, thanks for joining, everybody. This is Carol from the STS, and this is the STS National Database ACSD monthly webinar for February 7th. On the call with us today, we have our staff from STS, Catherine Holyfield, Addie Dolan, Derek Steck, Emily Conrad, our wonderful ACSD consultant, Melinda Offer, and special guest today is Dr. Moritz Weiler von Balmus. Dr. Weiler von Balmus will be presenting to us on frailty. So I'm glad you're able to join and hear about what's coming up in the next couple months and for 2024. I'm going to go over some quick STS updates first. The February training manual has been posted. The beta blocker data collection form started on January 1st, OR dates January 1st for isolated cabbage cases. We do have sites entering in the data, so thank you to those who are providing that voluntary form to us. To the STS, I have heard from one vendor that we provided the data specifications to, and they're undergoing testing now. So we do have vendors working with us to implement those fields into their software, and it is voluntary for them to do that. So don't expect your vendor to do it. It's something that they're offering to do for you. And right now, like I said, we had one that has reported into us that they were able to get that built, and they're undergoing testing at STS right now. Harvest 4 reports will be were released, and then Harvest 1 closes on February 23rd. And then here's our timeline. We're here today at the monthly webinar. I added in another webinar next week on February 10th. This is at 3 p.m. Central Time. So a day ahead, an hour later than our normal time. It'll be on Tuesday. I believe this is Tuesday. I might have even got oh, I'm sorry. This is the date. February 10th is the date that the executive dashboard is going to be fixed and a new release will be posted. We're going to have a webinar on February 13th, which is Tuesday, and this will be at 3 p.m. Central Time. So again, that's February 13th at 3 p.m. Central Time. It's a special webinar. We're going to focus on preparing for harvest close, and we'll go over those updates to the executive dashboard that regarding the missingness table on the dashboard. So if you're able to join, I know it's the last minute. If you're able to join, please do. Otherwise, it will be recorded and hopefully posted before harvest close. We have a database quality webinar, improvement series webinar scheduled for February 21st. Right now, I think we're going to go over the beta blocker information. And Melinda, sorry to call on you. I believe that was our plan for the 21st webinar. Did you have anything else we were going to go over for that?
No, I think we were gonna just devote that to the beta blocker.
Okay. And then thank you, Melinda. And then harvest close is February 1st. I'm sorry, February 23rd. Harvest 1 closes. It's OR dates through December 31st, 2023. Opt out for Harvest 1 is February 27th. And then our next monthly webinar will be March 6th at 2 p.m. Central Time. Again, just another snapshot of when the harvest closes. Harvest 1 is February 23rd. Harvest 2 will be closing on March 24th. Harvest 3, August 23rd, and Harvest 4 is November 22nd. Okay, so let's see. I'm just checking the questions real quick. We'll get to those after we go through the presentation, and I'll be able to respond to those with Melinda's help following Dr. Weiler von Balmus's presentation. If you raise your hand, we'll get to those when we get into the discussion part of this webinar as well. And then Beth saying, great to see those dates later dates for the harvest close. Yeah, we took in your feedback when we determined the harvest close dates for 2024. So I'm happy that we are able to slightly accommodate with later dates. All right. And now I'm going to hand it over. I'm going to hand it over to Dr. Weiler von Balmus, who is the System Chair, Cardiovascular and Thoracic Surgery, the Physician Executive Lead, Heart and Vascular Service Line for Texas Health Resources. Dr. Weiler von Balmus, please take it away.
Carol, thank you so much for having me. It's truly fantastic. I see 452 people on this webinar now, 455. So it's truly astonishing to have all of you joining this effort. And I first want to start off by just thanking all of you, all the data managers, everyone here on the call, really, for all the tremendous work you do for our national databases that make everything possible. It's my pleasure to talk to you today about frailty and what we have planned for introducing frailty in a systematic way of capturing frailty into our national databases. And Carol, if you could go to the next slide. These are my disclosures, and really what I want to touch on today is why frailty is so important. Some of that many of you may already have seen at AQO. We had an opportunity to talk about that. Maybe some of you were at STS in San Antonio just a few weeks ago, where we had another session on frailty, really geared towards the physicians. And so I just want to briefly touch on why frailty is so important, how we picked the metric and data collection we chose and why we did so, and then really spend a little bit more time on the technical aspects of the data collection and give you a timeline and a sense of where we are with things, what the rollout looks like. And then I think point number 5 is really questions, which I hope we can spend a good amount of time on. Next slide, please. So just briefly, frailty is, if nothing else, you're taking away from this today, it's frailty is a common finding amongst cardiac surgery patients, thoracic surgical patients. And it tracks with age, but it is also a condition that's really independent of biological age and therefore an independent risk. And therefore so important that we capture that in addition to all the other information we already have in our national databases. Next slide. And to just illustrate that point in numbers, this is a study with Medicare beneficiaries, almost 300,000 of them, where we looked at isolated CABG ABR, and isolated ABR. And what we did is we adjusted for our current risk models, for our risk, we did the risk adjustment using our current risk models. And then we added frailty. And what you can see is that there is a dramatic increase with frailty for 30-day death, prolonged ventilation, stroke, renal failure, and non-discharge home. And these are not small numbers. It's 2-fold increased risk of death, 4-fold increased risk of ventilation. That's okay, Carol. Yeah, and the same carries over through 30 days up to 1 year and further. Next slide. Another way of looking at this is looking at how frailty and here assessed with the 5-meter walk test translates into operative mortality on the left-hand side. That's the curve with increasing frailty measured by the 5-meter walk test. You can see how there's a dramatic increase in mortality. And the other way of looking at it is how our models are performing using our current risk models and risk-adjusted performance metrics. And what you can see is that right down the middle with a 5-meter walk test between 4 and 8 seconds, which is patients that are not extremely fit and patients that are not really frail, you see the models do well and they're well calibrated. The actual observed mortality tracks with the expected mortalities from our model. But if you go into the population where people are really fit, where they have a really short 5-meter walk test, you see, because we are not assessing the fitness of these people, we're actually overestimating the risk. And on the flip side of it, if you go over to the patients that have vulnerabilities and aren't as robust, you see how we're dramatically underestimating the risk. Next slide. So in brief, if we don't have standardized frailty assessment of all patients, well, for one, we can't really make shared decision-making that is based on complete information. In other words, our shared decision-making is based on incomplete information. And secondly, our risk models and risk-adjusted performance metrics are essentially incorrect. Next slide. So understanding that we're asking to collect more information and that means more work to be done, we set out to really identify something a frailty assessment or vulnerability slash fitness assessment, which is probably a better way to think about this in general than just talk about frailty. It's really assessment of fitness and vulnerabilities. That we wanted something that is low effort and high yield, that was robustly validated and essentially agnostic to diagnosis and procedures. And so what we landed on is two components, the clinical frailty scale and time chair rises. The reason we picked the clinical frailty scale is really because it's so easy to do and so applicable to a large variety of patients, whether those are inpatients or outpatients, whether you have patients that are bedbound or in a wheelchair. It can be done by the help of a proxy, a family member. So the versatility, the robustness of the clinical frailty scale, and how it's widely been validated and how it is applicable to really all kinds of procedure is a major reason why we picked the clinical frailty scale. The time chair rises are an additional element in this to assess just the physical fitness level of patients as well. Next slide, please. So in brief, the clinical frailty scale assesses a couple of different domains. It's essentially ADLs, instrumental ADLs, general health, stamina, and activity, if you will. The time chair rises are a easy to do exercise from a sitting position, from the chair that patients typically would sit in your clinic space, or a chair that's usually available in a bed in a hospital room. Of course, patients that are intubated or are bed-stricken for other reasons, that component wouldn't be able to assess, and we'll get into that. The data collection for this is really the responsibility for the data collection lies on the clinicians. And this has to be completed by the clinicians with the patient preoperatively and documented. Next slide. This is just a brief overview of what the data collection form is going to be looking like. We're finalizing this, so you don't have to copy that. You'll all receive that to have a template to work off of, but I just wanted to briefly show it. Next slide.
I'm just going to stop here for a second, Dr. Weiler von Balmus, because I know
Sure.
people are taking screenshots of this and they want to know, what questions are going to be asked. So just want to hold there for a second and show them. I'm sure that that's harder for them to see, but I know they're taking, I know my data, I know our data managers are very interested in the
absolutely, and I
questions.
appreciate that and understand that. And certainly, we'll also get to it in a following slide where I'll actually show you how we do this here at our institution. So this is just a brief video that shows the time chair rise exercise. Essentially, the patients are asked to stand up from a sitting position 5 times. There's instructions for how best to perform that exercise, and we can skip over that video. We will obviously provide instructional videos for that, as well as a written instruction for how to perform that test. It's a simple test, again, especially for patients that come to the outpatient clinic, but also something that can be easily performed on inpatients that are mobile enough to get out of bed and sit in a chair. Next slide.
Do you want me to go ahead and play this for them, or?
No, that's okay. We can
Okay.
skip over that.
Okay.
Just a few more sort of administrative details on how we're going to do this. We'll be using RedCap until a next version upgrade of the database would become available, where we could incorporate that. We're working with vendors to facilitate the data entry. And many of you have, again, probably heard that before on the AKO webinar at other occasions that we've talked about this. Next slide.
Oh.
So, same story, different way of visualizing that. The workflow for collecting the frailty information. The ask is really to the clinicians to do the 6 questions and do the chair rises and then document that in the EHR. And we do understand that every time we ask clinicians to do extra work, it means workflow issues and finding out how to operationalize that. To give you an idea of just how burdensome that is or not, what I did is I took a patient yesterday in the afternoon and did this myself. I work with mid-level providers that typically do this for me, but just to showcase how long it takes and how complicated it is or not, I will show you what I did. And did we skip over a slide or? Nope. If you want to go back, yeah.
Hold on, I have it on my other screen. I must not have gotten copied in.
No worries.
Sorry about that. Okay.
So what you will see in the video is me doing this real time in clinic yesterday afternoon. Now I understand that I will not get it. I'll not be getting a star in Hollywood for this for the cinematography, and it's slightly the timestamps are not quite correct either. But what you see on the left-hand panel is me sitting at the computer, talking to the patient and walking through the few questions. And then the video on the right-hand side, I don't know if we can play those, Carol, but what you'll see on the video on the right-hand side is what we did here is we made a very simple Epic template where you have a smart phrase, and Epic just happens to be the EHR we have, but that's, you know, yeah,
Let me-
if you hit that click.
Yeah, let me play on both of, so let me play this one. Can you,
So here I punch in frail, and then what it pulls in is the exact questionnaire you've seen before. And if you can hit the other video, perhaps, that shows me doing
So the
this
next
in
thing I would like to do is ask
real
you a couple
time
of
with
questions.
a
Those are
patient.
questions we use for screening and
I'm
to find
just
out how much
walking
you're able
through
to
it
do
and
and also how
simultaneously
much help
chart
you
it.
may need
Now,
with certain
there's
activities,
definitively
how
different
much
ways
to
of
engage
doing
in
this and
sort of
how people
sports
are
and
will be
more vigorous physical
get
activities
obtaining that
together.
information.
And
But
then
the
at the end
point
of
here is
this, I'll
that
also have you do a
it
quick
takes
exercise
less
with a
than 3
chair where you
minutes to
have to
do
get
this, and I'll
up
just
from the
let this
chair,
play
and
for a
I'll explain
minute
that.
so you can see for yourself or time it for yourself to see just how quickly.
So the next thing I would like to do
I don't
is
know why it
ask you a
restarted. I'm
couple
very
Or
sorry.
maybe we'll move on.
sort of
Yeah,
sports
okay.
and more
But I think
vigorous
you
physical
get the
activities,
point
okay?
here. It takes
And
less
then at
than
the end
3
of
minutes to
this, I
do
also
this.
have you do a
And
quick
what you're
exercise on the chair where
capturing
you
is
have to
a
get up
twofold
from the
increased
chair, and
risk
I'll
of
explain
death,
in more detail what the
fourfold
chair
increased risk
portion
of
is.
prolonged
So my
ventilation,
first
stroke, renal
question for
failure,
you is,
non-discharge
what
home. And
activities
Carol, you can
may
go
need
to the
help
next
with
slide.
at home?
You did all that work and I wanted it to be showcased your attempt for an Oscar.
And I just have this slide, you know, a lot of us like to grab a cup of coffee throughout the day. And I was wondering, how long does it take for, if you go to Starbucks and you place your order until you have your order? So on average, information that you can get on this is 3 to 5 minutes or somewhere around 4 minutes. Doing what we will be asking participants to do to assess frailty takes less time than this. So, you know, it's just as a to be a little bit controversial and to kick off some thinking around, you know, how can we convince people that will be pushing back that we don't have the time for this. This is too burdensome. It's really not. And we just have to, I think, all understand how important frailty is and how much of a difference it makes for our patients to have that information. Next slide. So here's a few points on the rollout process. So we're going to be rolling this out into the adult cardiac surgery database first. Ultimately, we'll want to collect the same information in the general thoracic surgery database. And we really want this on all patients, not only the cases that have a risk model, but really all the cases, elective, urgent, emergent cases, really. If you think about it, every patient that goes to the OR should have this 2.5, 3 minute assessment for frailty before going to the OR. The go live date is April 1st of this year. and mandatory reporting will start January 1st, 25. Next slide. So again, same information all over. We've spent, time at AQO last year in fall, and then this year at the STS annual meeting to really provide education around this. At the meetings, we have this webinar today. We'll be planning another webinar on the same topic after the go live date, and we will make abundant materials available also before the go live date, which are training manual, user manual, videos, instructions for how to do that, and suggestions for how to operationalize it at your institution. Next slide. So again, there will be a user manual for the clinicians to understand how they should be asking these questions, how they should do the chair rise exercise. There'll be a training manual for all of you data managers. There's a data collection form, and we'll supplement instructional videos, especially for the chair rise test, which, if you've seen it once or twice, it's, I think, pretty easy to understand how to do this and straightforward a test. Next slide. And that's it. So I'll be happy to answer any and all questions. I'm sure there's going to be plenty of those, and I'm looking forward to that. And I'll hand it back to you, Carol.
Thank you so much, Dr. Weiler von Balmus. A super important topic that we, as the data manager community, are going to be absolutely happy to help with in realizing the importance for our cardiac surgery patients and assessing their predicted outcomes. So thank you. Just a slide from me. April, I see the hands raised, and I'll come over to you in just 1 second. Again, April 21st will begin data collection. We want to give sites time to get up to speed with this, implement it, so you're successful, either building it into your Epic, training your providers, your clinical providers who will be doing the assessment, and getting processes in place so that you could be successful at the mandatory date of January 1st for collecting this. And it will be on all cardiac surgery patients, analyzed and non-analyzed cases that are entered into the adult cardiac database. And like Dr. Weiler von Balmus stated, the plan is to expand this to GTSD following the implementation within the ACSD. Data entry will be into the REDCap form, and we will also work with the willing vendors or vendors who are able to build this out for their sites as a supplemental form that will link to your vendor software for the demographic information, patient demographic information, so you don't have to re-enter that. More information for that from STS will be shared with the vendors in the coming months. We also want to give them an opportunity. That's why we made the mandatory date January 1st. So thank you, Dr. Weiler von Balmus. Of course, we have a ton of questions from our data managers, and just our quick resources for all of those: STSDB_helpdesk@sts.org if you have questions on the IQVIA platform. And then please use the raise hand function if you'd like, or the Q&A question function, and we'll answer as many questions as possible. And if you would like me to go back to any slides, please just put that in the Q&A. And okay, so let's start. Are you ready, Dr. Weiler von Balmus?
Yes, absolutely.
Okay. How do you measure this if the case is an emergent CABG patient, emergent case?
Yeah, so that's an obvious question, right? How do you handle this if the patient, say, is coming, an emergent CABG is one, but say a aortic dissection is directly coming from the helipad. So we understand that documenting in those specific instances preoperatively is probably not very realistic. The clinical frailty assessment is not specific to that time period right before you go to the OR, but it's really to the functional status prior to the acute illness. So while we do think that this should be routinely collected in patients preoperatively where it's possible, because it does help with the shared decision making, and it does help with probably tailoring the care for the patient. We do understand that there are specific scenarios where that's not possible, and we do understand that there are specific scenarios where the chair rise exercise is not feasible. So good examples of that are, well, someone coming in with a aortic dissection directly from the helipad goes to the OR. The data on frailty and these questions surround, these 5-6 questions surrounding the functional status and fitness of the patient can still be answered post-operatively. So the information can still be collected and documented. Cath PCI uses the clinical frailty scale, and they ask everyone that goes to the cath lab, including STEMIs, to have that completed. They use a slightly different process, which we think is much less reliable, which makes it a little bit easier to do it even if you rush off the patient from the ED, say, to the cath lab. So there's certainly a balance between the two of them. That being said, the expectation would be that patients have this completed preoperatively, and it flows into into the care team's decision making for this patient. But if it's not possible, it's possible to document it post-operatively.
Thank you. They have a couple questions regarding who's to collect this information or document this information. Our last call, it was mentioned it should be by a provider. This call, we mentioned it could be by a nurse. Is there any consideration if this is delegated from the nurse or physician to an LPN or CNA regarding who can document this information?
Yeah, some of that is maybe a little bit semantics. What is a provider? Is a nurse not a provider? So, it needs to be completed by someone with some medical background. A nurse would be okay. Advanced practice provider would be okay. Some sites have, that do frailty assessment involve PT, for example, for the exercise portion of some of these assessments. It needs to be someone who goes with the patients through this. We don't necessarily want sites to just hand a questionnaire to patients and they just fill it out on their own. It's a more deliberate act of someone on the care team going through these questions and answering those with the patient. But it can be a nurse, it can be an advanced practice provider, it can be the surgeon that would be doing that.
Great, thank you. The question from Angela about if the slides will be available, they will be available. Please just give me, hopefully by mid next week, we'll have them posted on the STS website under the webinar section. Ala is asking if there's a date that they will receive the instructional information. I can take this one. We are working on the training manual and finalizing the data collection form now. And then it will be available hopefully by the first couple of weeks in March. We can get the training manual completed and approved from Dr. Weiler von Balmus and his colleagues, the surgeon leaders here at STS, for posting. And then we will have a formal notification that will go out similar to the beta blocker communication. Probably mid-March, we're aiming. We usually do that about 2 weeks before we start a project like this. So does that all sound good to you, Dr. Weiler von Balmus?
Absolutely, yes.
Judy says, will this be presented to the vendors to give them the option to add this to their software? Yes, we'll work with the vendors and provide them data specifications, and the vendors that are able and willing to add this into their software for sites will do so. For the frailty questions, can they be sent to the patient via patient portal prior to surgery and have patient self-fill out, or does a clinician have to ask and document? Also, can you get frailty risk without the chair rises and just the questions? So 2 questions there for you. I think the first one you had answered and you said, no, this needs to be filled out. The clinician or whoever the clinician designates to ask these questions needs to be asked directly to the patient and documented right there. It's not a patient reported measure or form. It's a patient's reporting it to the clinician themselves, the clinicians to document. But for the second question, can you get the frailty risk without the chair rise and just the questions?
Yeah, so thank you for this question. And as you say, Carol, you're absolutely right. Part of the reason we're doing this is because, or the main reason we're doing this is because we recognize that currently our risk models and our risk-adjusted performance metrics are not accounting for frailty, which makes a huge difference. And people have said, well, why would I collect this information if it's not being used in the risk models and the risk-adjusted performance metrics? Well, in order to do that, we first need to have the information and collect the information. So it starts with information collection. And we want to have as good data as possible. So the idea of outsourcing this, if you will, to the patient, with just having patients fill this out, we think we don't get the same quality data back as if a clinician, a person, walks through these questions. There's a question also about cognitive function. And as you might imagine, someone who does have cognitive impairment wouldn't be appropriate to necessarily answer that question themselves. So there is an assessment portion from a clinician side involved in this, which makes it more granular and more useful information. The chair rise exercise is an additional component for us to make sure that we really capture not only frail patients, but also fit patients and have a better discrimination. As you may remember in the slide I showed, our risk models and performance metrics are off in two places. The obvious place where people are quote unquote frail, and again, maybe vulnerability is a better way to a better term to use here. But we're also off when it comes to patients that are extremely fit and are very much able to do things. And so if we were to say, well, we're just going to do part of this, or we're just going to use a lesser version of what we propose, the issue could become that we're maybe do better than what we have now, but couldn't really get to the full spectrum that we're trying to capture here.
Thank you. And thank you for that answer, Dr. Weiler Van Balmus. Regarding from AL is asking, can you explain the red cap, please? And new data manager who would like to understand more about red cap. So I can take that one. The red cap is a secure way to enter data collection, and we link it to the STS website by a few de-identified factors that are entered in with the cases in your vendor software, like patient ID, which becomes a de-identified variable the way the vendors calculate patient ID and record ID. And then REDCap collects the supplemental information for us, and then we're able to link it at STS Analytics using those de-identified variables for further analysis and understanding. We can explain more about REDCap on our webinar later this month when we talk about beta blocker. We do have quite a few questions here, so I just want to make sure we can get to the questions for Dr. Weiler Van Balmus, and then we can always stay on later and discuss things, other things if we need to. Completing another REDCap entry is burdensome for the data manager. So thank you very much, Annette, for that comment. We I think we certainly understand the data entry burden for sites and try to space things out. The beta blocker data collection is going to run for 1 year from January 1st to December 31st of this year. And then the data collection for frailty, it starts April 1st this year, but becomes mandatory January 1st of next year. So we tried to space those out a little bit to help being considerate of the fact that the extra work sites are going to need to do for this frailty assessment. Additionally, the beta blocker form is voluntary. While we want all of the data, consistent data for sites for isolated cabbages, It is voluntary. It's not required for the STS database, but we do ask that you complete it consistently at your site if you're able to participate in that. So I certainly appreciate the data burden, and thank you for that comment. A suggestion from Sarah Perez is, could the MA maybe do the chair test when getting vitals and report the findings to the surgeons? Would you be okay with that, Dr. Weiler von Balmus?
Yeah, again, we're not, we understand that there is local circumstances that may make one implementation easier over another. So we're certainly not here to prescribe exactly how you collect that information. It's unfortunate that the video didn't run. It was just one example of how you could operationalize that. And certainly, having an MA or a nurse do the chair rise exercises is a very reasonable approach to this. Again, the goal here is to collect the information and do it, reliably and have good information so we can use that to improve our modern performance metrics.
Okay, and we do have time to run video. Do you want me to run this one or the one of your assessment for the patient?
That's okay. I wonder if it's more helpful if you just go through questions, and
Okay.
I don't know if with the video running, the voiceover, if it's going to
Yeah.
be more confusing if we have.
Okay. No problem. Will there be a concrete list of inclusion exclusion criteria? I know there's questions for how this will be done for emergent cases. Do you want us, Dr. Weiler von Balmus, could you please speak to the inclusion criteria that we're looking at?
Yeah, so we look to collect this on all patients, emergent, non-emergent, all procedures, really to not also ask every site to think about when they should be collecting this or not. It's understandably a different scenario if you have someone that goes to the OR emergently, but as I've alluded to, it's very possible to collect that information. That was part of the reason how we landed on the clinical frailty scale as the tool to assess frailty. And so the answer is all patients that go to the OR.
Thank you.
Can I ask a question just to clarify that? So
Sure.
when you say to collect the information on all the patients, so when you're talking about that for the emergent cases, you're talking just about the fertility assessment, not necessarily the chair raises. We wouldn't want to do those post-op, correct?
Yeah, well, so there's, I think there's a few questions in the chat. What happens if a patient can't complete the exercise, or what if the patient can't do the exercise, say, because they're intubated? There's going to be an option that can be checked for that. So if the patient can't complete the exercise, if the patient if it's impossible to assess because the patient, say, is intubated, there's going to be an option for that. Yes.
Thanks, Melinda. Will you share your epic smart phrase? Willing to share your epic smart phrase?
Yes, I'd be happy to share the smart phrase. It's really it's really super simple. So what you can do is quite literally mark the data collection form, copy, go into Epic, paste, mark it again, right click, add smart phrase. But I'm happy to share that. So
Oh, that's easy. That's easy to do. So you just highlight this.
Yes, Epic is
Copy
Epic is smart enough to recognize the little boxes, and then you can just click them. So it really doesn't get easier than that. And I'm happy to make a video on how to do that. That we can also include, so people who do have Epic can just use that same process. But it's literally copy and paste. So very simple to do that.
We're going to have a EHR Epic class with you. Come back for an Epic only webinar.
And I don't want anybody to get the wrong impression. This is no endorsement of Epic in any way, shape, or form. We just happen to have Epic, and I know a lot of people do. I'm quite confident that a similar process also works with other EHRs. And then there's always, if someone says, I just want to have a paper in front of me, there's always the option of printing out the data collection form, sit down with a clipboard and a timer, and check the boxes off, scan it, and put it into the EHR. So that I think, again, it doesn't get simpler than that. And there's certainly different ways of operationalizing that. And again, we're not prescribing those details.
Yeah, thank you, Dr. Weiler von Balmos. And by no means are we endorsing any one EHR, but it might be helpful in the future if we could have, maybe we can talk about that, Melinda, you and I can talk about that and see if we can find some super users for each of the EHRs out there that we could try to be inclusive and have something for our data managers that might help them with their responsibilities for the database related to that. And you did answer a couple of other questions. One question I do have, if they were to scan it into the chart, would this need to be signed by a physician or by a provider so it becomes a legal, becomes part of the chart in an event that we ever audit this information or anything like that?
Yeah, that's a good question. It's honestly outside my expertise. The institutions I've worked at, there once in a while there would be things that got, filled out in paper form and then scanned into the EHR, and by virtue of attaching it to the patient, it was part of the legal documentation of this patient's chart, but I've never actually signed it it's a great point. I'm honestly that this is outside my my expertise, and we would assume if this gets dropped into a patient's chart as a copy, a PDF, if you will, for the audit purpose or looking back, well, it's attached to this patient's chart. I mean, it's whether it's signed or not, I don't know that makes a difference.
Yeah, that's a good point. And it's probably site specific too. So maybe even just reaching out to whomever at your site's responsible, maybe in the health information management department would be able to help with that. If the frailty scale and time tier rise is done in the clinic, is there a time frame that it needs to be done in relation to surgery?
No, so if I understand correctly, the question is, what if a patient is seen in clinic, gets the frailty assessment, and then say scheduled for surgery in 2 weeks later, and then there's maybe a delay and it gets pushed back another 4 weeks. Is that frailty assessment still valid? Yes, there were some dramatic changes, and it's like everything, right? I mean, it's not. I wouldn't equate it to a lab test that has to be, within a certain time frame, because it's really critical to know that your lab numbers are accurate before you go to the OR. But it's part of the assessment. So no, we won't be telling you, it has to be complete within 2 weeks before surgery or what have you.
Okay.
It just needs to be documented.
Okay, thank you.
And these are, maybe just as an aside and more context, the fitness vulnerability status of a patient doesn't, typically change that much. And the questions are geared towards things that are, usually existent for some time. Struggles with washing and bathing are typically the ADLs, AIDLs are present for a while and do not, change overnight. So it is a longitudinal assessment by virtue of how the questions are phrased and what it's getting at.
Okay. Can you talk about how this is going to impact star ratings, if it will, and if so, when?
Yeah, so, once we start, as I said, the goal will be to use this in our risk models and risk-adjusted performance metrics. And what it will do is it will make it more fair. Right now, if you have a patient that, has a STS from of like 3%, say, but the patient is, frail, slightly frail, maybe not so that it's quite apparent to the surgeon, and the surgeon goes to the OR and the patient, has a bad outcome. Well, then it wasn't really fair to say that the predicted risk of mortality was only 3% because the patient was frail. So, it will, having this information will lead to better risk, uh, better risk models and risk adjusted performance metric, and as such will factor into the star rating, but in no different way than the current risk models and risk adjusted performance metrics do.
And do you see this ever being connected to the failure to rescue model that we're working on, that's being worked on?
Yeah, great question. So those things are tightly linked. So there's a lot of literature on that topic, linking frailty to failure to rescue. And again, the only way to judge more fairly failure to rescue is by having this information up front. And that's why it's so important. Absolutely. Frail patients have a much higher failure to rescue rate. There's a ton of literature out there on that. So without having this information, we're not currently able to fairly assess any of these things. And that's true for 30-day mortality, morbidity, and failure to rescue.
Thank you. And that came from our Michigan collaborative. That question came from our Michigan collaborative. So I'm sure they're looking at that as well.
Right.
They're also working on frailty. When this was presented at the STS annual meeting, how was the reception? How did the surgeons receive it? And what kind of questions did you get regarding maybe emergent cases or other cases like that, that they see any difficulty in obtaining this information?
Yeah, I think, we had a very nice session with a very full room, despite it being at the very tail end of STS. And it was nice to see so many people in the audience. Sometimes the issue is a little bit that, you end up preaching to the choir. The people who show up to these things are the people that are already engaged in that space and understand the importance of it and have been working at this for some time. But there were people who were critical about this. And so I can give one example. I think that exemplifies to some extent the issue. There was someone who went up to the microphone and said, well, it does not really make sense to assess frailty in everybody, because why would I assess frailty in someone who is young and not frail? Well, the issue is that if you don't assess frailty, you don't really know who is frail and who isn't. And the other part you're missing is those people that are really fit. And so it distorts our risk models and performance metrics on both sides of the equation. Those who are really fit and in really good shape and actually should have better outcomes that we're currently predicting. But more importantly, in a larger proportion of our patients, we underestimate the risk because, well, sometimes frailty is not that apparent. And there's a lot of studies that have looked at the eyeball test and clinicians just gauging whether a patient is at higher risk or not in terms of frailty. And certainly there's patients where this is unquestionably the case. And those are the very extreme cases. But the patients that benefit most from a frailty assessment are those where it's not necessarily apparent when you talk to them. They're capable of doing things, but under the hood, if you will, they have significant vulnerabilities that put them at a much higher risk for morbidity and mortality.
Yeah. And to that point, there are questions here about, it becoming mandatory. What does mandatory mean? And with collecting this data, are the physicians, the providers, going to be able to access any type of data regarding to share this with and share decision making with the patient? And I know you just talked about it being included in composite ratings. So do you want to talk about the mandatory aspect of this related to the composite ratings, and then what the plan is, how this will be incorporated into any
Yeah.
maybe bedside calculators going forward for shared decision making?
Right. So go live is April 1st this year, and then mandatory reporting January 1st, 2025, which gives everybody essentially 8 months to figure out how to do that. The mandatory reporting means that we will be using completeness thresholds for this. And one way of thinking about this, perhaps for everyone, is to think, well, here I am, I'm doing heart surgery, and my partner next door is also doing heart surgery. If she or he does frailty assessment and has that additional information, she will get better risk stratification, and she will end up performing better than me because, well, the risk estimation is much more accurate for her patients or his patients than it is for me. So essentially, people who will not be collecting the information will be hurting themselves because they won't have the information to differentiate between those that are frail and those that are not frail. And that will be reflected in the risk estimation and the performance metric, as I've alluded to. And then what was the second question, Carol?
I think regarding, well, my question was about the bedside calculator. That was the second part you had
Oh,
answered.
yes. And so, yeah, so, to put this into the bigger context, one part is risk stratification, but that's really only the beginning. The overarching goal and the bigger goal here is to really help our patients better, right? If you don't really know if your patients are going to be high risk or not, or just based on the current models without having frailty, you may be quite wrong about what the risk is to the patients. So for shared decision making, we believe this is an extremely important tool as well. With the data that's being collected with those 6 questions and the chair rise exercise, every site will be able to calculate the frailty score. So it's and we will make that available as well. So every site can do that. Apart from that, there's certainly a plan to also let that flow into the online portfolio that we have, where people can enter that information and get the clinical frailty scale calculated, sort of associated risks with it, et cetera. So yes, absolutely. The idea is to make that, not only ask all of you to collect that information, but make it available to you for your shared decision making, and ultimately also for deciding what may be best for the patient in terms of the timing of the surgery. There's a whole topic of rehabilitation and how to optimize patients before surgery, especially patients that are frail, because some of these things can be optimized before going to the OR. But again, it all starts with systematically assessing frailty or vulnerabilities and fitness in the first place.
Thank you so much. And I think that's probably the most important thing out of this, is that we'll be able to give patients a better idea of what their outcomes are going to look like before they even go into surgery, and help them prepare for a smoother post-operative course. So a couple questions here regarding 6-minute walk test, the 5-meter walk test. Is the 5-meter walk test going away? Is the 6-minute walk test accepted for this? Any guidance on those questions?
Yeah, so very, very simply speaking, supplementation as much as you want, no substitutions. So we can't have different sites do different things, because what we will end up is the same problem we currently have with the 5-meter walk test. As many of you know, we have 5-meter walk test as a frailty assessment. It's only reported for about 10% of the patients. And that's the reason we've not been able to use it in our risk models and performance metrics, because it's simply not done enough. And if we were to allow people to use different tests or scales, we would run into the same issues. There's not really, those are all sort of accepted tests of frailty, 5-meter walk test, 6-meter walk test, grip strength test, all of these things. There's no translation between them, saying if you get a number on the 6-meter walk test, there's no agreement how that translates into a 5-meter walk test or grip strength or any of the other tools. So that's why it's so important that everybody does the same thing and everybody collects the same information and in a standardized fashion.
Okay, and a couple questions. I know we're getting close to time. I don't know if you're available to stay over or not. I can't keep this below 100 questions, so I apologize. But I think I'm not apologizing for the questions because I think they're really helpful in the learning process
Absolutely.
for doing this. If you're able to stay on, that's great. If you need,
I can stay on for another 5-7 minutes.
okay,
My next meeting a quarter after, and just I
Okay.
don't have to go too far. So certainly happy to stay on and take as many as we can.
okay, that's great. And then maybe Melinda, if you're able to stay on, we can stay on just for a little bit longer, see if we can answer any of these. But we should definitely plan to have you back, Dr. Weiler von Balmoos, in March before go live. To
Certainly.
make sure we're all set with everything. Okay.
Happy to do.
Thank you very much. If the patient's unable to do the chair rises without their arms, do they still answer that question? And another question into that, to combine questions for you, is if they're not able to do the chair rises, but we're able to get information for the rest of the assessment, do you still want the rest of the assessment answered?
Yeah, both all excellent questions. So for the first portion about the chair rises, there will be detailed instructions what counts and what doesn't count. And what I would encourage all of you to do is go home and find people in different age categories that you are around at home. It's not that simple, you know, to complete that exercise. And the execution is without using your arms, because it's an assessment of core strength and sort of core muscle mass. And that's why the idea with this exercise is not to use your arms to push yourself off the chair or pull yourself out of the seating position. And if you think about it, it ties in with what we see after cardiac surgery, right? If you have a sternotomy, we don't want people to use their arms to pull themselves up and pull the sternotomy apart and what have you. And so that's maybe one way of thinking about it. And so there's going to be clear instructions. You know, what happens if the patient cannot do all 5 chair rises, for example? What if they can't do it at all without using their arms? Well, those are fails. Those are all fails, and it would be, you know, there's the box accordingly that you would check for that. And so the other portion, I think the other question was, what happens if you do all the questions and then the patient can complete the chair rise exercise? Yes, we still want all the other information. So if you have a patient that is intubated in the ICU, you can complete all the questions, but you can't do the chair rise exercises. So yes, we will still want that information. And there's actually going to be an option to say, well, patient can't complete exercise because, for example, intubated or unconscious.
Thank you. Thank you. Other questions I'm seeing are, have we coordinated with NCDR for what they're doing? And I know you know the answer to that one, so I'll wait. And then the other part is, which is similar to what NCDR is doing, is just documenting the score. And will the site, the data managers aren't seeing a value on this page. Will they be able to receive back any score, or is there a way for the sites to calculate the score off of what we're collecting?
Yes, so all excellent questions. On the back of these few questions, you can do the decision tree for the clinical frailty scale and at least get that portion of the frailty assessment. NCDR uses the clinical frailty scale, but what they have opted to do is to tell the sites that the nurse taking the patient back to the cath lab just assigns a score. As you might imagine, this is no better than anyone just eyeballing the patient and say, well, it's a 4, it's a 5. And that's what seems to be happening. The challenge they will have with their data is that a lot of patients are just going to be a 4 and 5. And then it's going to be really frustrating because everybody sort of started doing this. And yet again, we can't use the data. So we understand that this is more involved. This takes more work than just picking a score. But just picking a score is also kind of meaningless. And this is the established shortest version of doing the clinical frailty scale as it has been, established by Ken Rockwood, and we work with Ken Rockwood on this specifically also. So it's as easy as it gets, but as valid and reliable and reproducible as it gets as well. And that's why we decided not to pick the option of just picking a score and see what happens.
And I'm sorry, you probably just said that I was filtering through questions. Can we provide the sites with how to calculate the score if they're interested in that?
Yes,
for example, I
absolutely.
mean, if
Yeah.
this patient comes in for a CAF PCI and they have to provide the score to NCDR and they're already working on this, is there a method that they could use to calculate the score for CAF PCI from our data collection?
Yes. So if a patient comes in and you were to do this, you can calculate the exact clinical frailty score, which goes from 1 through 9. So it's essentially a number 1 through 9. Okay. And you can do that with having the answer to these questions, and that's why we picked those questions. We didn't come up with those on our own. These are from, again, Ken Rockwood and his work on how to do the decision tree for the clinical frailty scale. The other way, it doesn't work, right? If a patient were to see a cardiologist and say, oh, we're going to do PCI, and they just pick a number, and then the decision was made, oh no, we're gonna go the CABG route now. You would still have to complete this. And if you run into these, I would encourage you to look at what number you end up getting from this versus the number that was picked just based on, eyeballing the patient and assuming what the number might be. And you'll probably be surprised how often those two numbers would not be the same ones. The reason I did not talk about how to calculate the clinical frailty score off of this is because we said we want to make this as easy as possible, and we'll provide everyone with tools to have the clinical frailty score reported back. So you can use it for research, you can use it for your shared decision making, but we just got to get the ball rolling on collecting the data. The decision tree, the algorithm, if you will, for how you arrive at the clinical frailty score is relatively straightforward. It's pretty simple, and we'll provide that.
Thank you, Dr. Weather. Yeah, thank you very much. We'll provide anything that's helpful if we can provide it.
Absolutely.
Two final questions, and then we can dismiss you from this. And then Melinda and I think, Melinda, are you available to stay on with me for a little while? And Catherine?
Yeah.
Okay.
Yes.
For emergent cases, the frailty questions can, of course, be done after that case is performed. Do you want the chair rises for those types of patients where they're unable to perform chair rises to be marked as unable to assess? Since is this supposed to be a pre-procedure chair rise, or is it okay to do it afterwards?
Yeah, so again, if someone comes in as an emergency and can't even complete a chair rise exercise because they're intubated, or there's such a high acuity emergency, not much is gonna, you're not gonna change your plan of action with a chair rise exercise, right? So we understand that in these instances, the chair rise exercise will not be possible to complete, and there's probably not a ton of value of doing it after the fact, because post-operatively, there may be reasons why they have challenges doing this that are not necessarily related to their level of fitness or frailty. So, and again, we'll specify that in the user manual and the handbook that patient, the clinical frailty scale, the questions you can complete after the fact, if you will, after the surgery, because they ask about how patients were living prior to the procedure. Not the moment they came into the hospital. The exercise is a little bit different, and the plan, it would not be necessary to collect the chair rise exercise in those occasions where it's not possible to do it up front, to collect that after the fact, because it would just not provide really helpful information.
Okay, and then for those emergent patients that say they happen to die after surgery, or they have a really rough post in hospital, post-surgery stay, and they die in the post-operative period, and this is not able to be complete. My guess is that we would just exclude those cases from the mandatory reporting requirement.
Yeah, I mean, there's always going to be one-offs, right? I mean, we know that from other things, there's going to be one-offs, and I think we have ways of handling the situation across the database with other data collection points. So I don't think anybody is unreasonable, and we all understand that there's going to be the one-offs, but in general, the goal here should be to collect this information.
Okay, thank you. And then one final question, and then you can go, just to wrap things up. This is a draft of the data collection form. It's pretty close to being final, but I think we probably still have some tweaks to add to it. And I just want to get your timeline for when you think we'll be able to share this with the sites.
Yeah, so my hope is to get that out in relatively short order. I understand that everybody is wanting to get ahead of this and implement it. And it's again fantastic to see so many of you on here and the enthusiasm for it. And I can't express enough how grateful we are for all of you to help implement that. So it's a very high priority for us to release the final version of this. We want to again make sure that we have nailed it down. I've seen some questions about the definitions. These definitions are actually given by Ken Rockwood's work, and some of them are, have a level of ambiguity in them. For example, I think someone pointed out how, what is how I'm just going to pick an example here. How do you differentiate between excellent and very good? Well, some of that does have a level of subjectivity. Again, it's a balance between this, not doing it at all, and something that's much more complex and takes much more time to assess and document. And we did our due diligence. We went through all of these. We weighed different options, and we got confirmation from frailty experts really across the globe that these are valid ways of collecting this information.
Great, thank you so much. Thank you, Dr. Weiler von Balmus. I won't make you late for your next call. Thank you for joining us, and we'll invite you back, and we can follow up after this call. Just you, Melinda, myself, and Catherine to discuss next steps for finalizing this, working on the training manual, finalizing that, and getting this out to sites as soon as we can ahead of April 1st. And Melinda, Catherine, if you could stay on with me, we'll go ahead and answer as many questions as we can up until about 3:30 Central Time. So again, thank you so much, Dr. Weiler von Balmus. Always great to see you, and have you work with us and the data managers and answer all of our questions. So thank you. Okay, Melinda, are you ready?
Is to work with all of you. Thank you again to all the and thank you.
I'm here.
Okay, sorry, I think Dr. Weiler von Bommels, you had cut out, but I heard your last sentence. Thank you. Okay, Melinda, ready?
I'm here.
Not ready.
Well, I'm learning all about this just like they're learning all about this. So
Yeah,
we'll try to work through this together.
we're gonna work through it together. Okay, I'm gonna go to the top of the questions. If you all want to stay on, you're free to stay on. We're gonna stay till about 3:30. How many programs are participating in the beta blocker collection form? This is from Joy. I don't have that number right now. I can tell you we have just about 800 cases or just near 800 cases. But it's still pretty early on because it's the first week of January. So sites are still cleaning up end of year data, preparing for harvest close. So we'll have a better idea of that around April. Is there a place to get a copy of the beta blocker data collection tool? So that is on the STS website. Let me pull this guy over here. Under the data collection resources. Y'all see my screen okay?
Yes, ma'am.
Under adult access data collection. If you go here, and then under version 4.20, Melinda has nicely added in the beta blocker section to the training manual. And then the data collection form is here. We have it in the annotated PDF version and the Word version. The training manual, if you open the training manual up, you'll see. So the data collection forms are there. The training manual, if you click over here, depending on, I guess, who your browser is, you'll see this little bookmark thing. And the bookmarks will open up. When you scroll down here, you'll see beta blocker supplemental training. Click on it and it brings you to the beta blocker section for the training manual.
Yeah, I also added one to the top too.
I tried that earlier and it wasn't.
Did it work?
It wasn't working.
Oh, for Pete's sakes.
That's all right. It might be my
Well, it worked on my end, so let me check it again.
yeah, and it might be when we transferred it over to marketing for posting, something happened.
Okay.
Can you say what vendor had the beta blocker field? I'm not sure the vendor's name that had that. It was just one of them, and they're going through testing right now. For the beta blocker, can we submit data after data deadline? Yes, that's fine, Heather. If you want to submit your data, we're just happy to get any data in on that beta blocker project. Asking sites to be consistent in submitting it for all of their isolated cabbage cases. And we just ask that you get it in for the year by the end of the year, within the first by harvest 1 of 2025. So we have it for analysis when we analyzed harvest 1 2025's data. What is the time for the February 13th webinar? That's going to be at 3 p.m. Central Time. It's a Tuesday at 3 p.m. Central Time. So, and a couple questions here about the beta frailty form being incorporated into the data collection form when it becomes mandatory. Right now, we do not have an upgrade planned for adult cardiac. So we're sticking with version 4.20.2. No upgrade is planned. This data collection form will, for the frailty, will be completed through REDCap, through the REDCap link. And if a vendor is able to, the vendors are willing and able to build this out as a supplemental form within their softwares, and you would be able to enter it there as well. For right now, there is no plan for an upgrade, so we will not be incorporating it into the data collection form. We'll be getting data outcomes related to this, even though it's going through REDCap. Buy-in from our financial partners and providers is difficult if there is no return on investment for us. Yeah, we'll figure out a way to get data back to sites and how to do that. The same with the voluntary beta blocker data collection form data. We will work out a process to get that back to sites that request it. Doing another REDCap form is burdensome for abstractors. Also getting implementation is burdensome. there's a lot of red tape to go through to get workflows changed. It takes months to get things changed. Yeah, that's exactly what I had shared with shared with Dr. Weiler von Balmus. And that is why we have the rollout process in place starting April 1st, giving sites until January 1st for the mandatory reporting on this. So you have 8 months to get yourself a process in place, start capturing this information. And hopefully by January 1st, all of that will be resolved at your site. So you'll have it, if you need to build it into your EHR software or anything like that, giving also vendors enough time if they're able and willing to build this for their sites in place of the red cap data collection form. So that was the whole plan. That was the whole discussion between these two dates, the April 1st go live and the mandatory date of January 1st.
So Carol, what does that mean exactly? I'm sitting here thinking, does that mean like if I'm not ready, April, but I get ready in June, I can start in June? Is that what that means?
Yeah, that's exactly what it means. So we want sites to start participating as quickly as, as soon as possible. But we also don't want to make the burden at sites to where they're, starting one process just to hurry up and get this going, and then implementing another process to get it into their EHRs halfway through the year. So if sites are ready to collect this data April 1st, we absolutely would want sites to do that. But we also want to be, mindful that there are programs that they have to go through. Like Beth said, there's red tape that sites have to go through. If it's working with your IT team, if it's working with your surgeons or the clinics to get a process in place for getting this assessment done. I mean, it's a change in practice. So we're trying to be very aware of that, Melinda, and making sure that, we don't force sites into something that they're not ready to do, causing, them to have to change their process halfway through when they could just start off doing it a way that is going to flow much better for them, given a few extra months to prepare for it. So April 1st, we're going to start collecting the data on frailty. By January 1st, we want everybody to be collecting it. Does that answer the question? And does that sound reasonable to you? I mean, if
Well, yeah,
8
I
months
think
is not
that
enough, I don't know.
I think that people are concerned that they're not going to be ready. But I think when you break it down and say, hey, we're giving you time to get ready, just because we're going live April 1st, if you're not ready, it doesn't mean, you have to do it, but we'd like you to get ready as soon as possible.
Yeah.
I think that's good. I think it's good.
Yeah, and Dr. Weiler von Balmus was very willing to make flexibility in the mandatory go live date because we want people to be we want the sites to be successful at collecting it. And we don't want it to be a huge burden. I mean, we're doing this beta blocker thing extra as well. So we're trying to be thoughtful of that instead of just pushing it. So yeah, thank you. Can I go over to the hands raised? Because I know Nicole has had her hand raised and Kim, and then I see Heather now. So I'm going to go ahead and unmute you if you're able to talk. Go ahead, Nicole. And Heather. Go ahead and interrupt me if you're able to unmute. Okay. And I'm going to go on questions until if they're able to unmute. Can STS send out a notification once the slide deck is posted to the website so we can share with our providers? I'm going to send this over to our marketing team, usually probably this evening with the slide deck, and they'll have to render the recording and then post the slides. It probably is going to take about a week. I don't know that we can send out official notification. We have so many notifications going out, but I don't know. I'll be able to coordinate with that with marketing so quickly on that. We will be sending a notification out next week usually on Monday regarding the upcoming webinar on Tuesday. So I'll see if we can add it there. I don't know if it'll be posted or not. Otherwise, I'll provide an update on the slides posting on Tuesday's webinar.
Hey, Carol, it's Heather.
Oh, hey, Heather.
Just a quick question about the mandatory reporting. I saw a question in the chat that I thought was valuable. Is there going to be a threshold for reporting? Is there going to be a % missing that's mandated? So
Yeah, that's a great question. And I saw that too. I was hoping to get to it. But I didn't, I know that I talked about this with Dr. Weiler von Baumholz yesterday, and we don't have any set thresholds right now. So it's something that still needs to be discussed with the STS leadership as to what that would look like. I reminded him about when we implemented the mortality threshold and how we did it in steps, right? We started with 10%, 5%, and then we went down to the current 2%. And so it may be something that looks like that. I just can't say for sure right now what it's going to be. So it's a discussion that's, a little bit higher up on the totem pole than I am and than where he is. So it's on the list of things to discuss and finalize, because I know that that's going to be important. But I suggested a stepwise thing where it's like a 10% missingness to begin with. And of course, there'll be, criteria where, we have to be mindful about patients who are emergent cases that die after the procedure in hospital and things like that to be mindful of. So, yeah, absolutely. Thank you for bringing that question up. Did that answer it, Heather?
yes, it did. Thank you.
Okay. When can we expect to see the cleaner copy of questions needing to be asked? Yeah, at my hospital, it'll be a process to get this in place. Absolutely. So I'll follow up with Dr. Weiler von Baumholz on Friday. I'm out tomorrow, so I'll follow up with him on Friday and then see what our steps are, what he needs to do to get, who he needs to talk to get this finalized. If there's other surgeons or physicians that he wanted to run this by first before posting. Otherwise, I think it's pretty close to the go live version. If you do direct data entry into IQVIA, is there plans to have these questions embedded into the data collection form? Not at this time, Elizabeth. Can the red cap forms be consolidated? There is one for devices not in registry, the beta blocker, and now frailty. Yeah, I hear what you're saying. Let me see. So the beta blocker one is for just the isolated cabbages. The device one is for the valve patients. The frailty one is going to be for everybody. So Jody, it's a great suggestion. So certainly something I can talk to our red cap person, Nikki, about and see what she suggests if there's a way to do that. But I don't think that all of these patients are going to span. Maybe on the beta blocker one, we could add it in, but let me talk to her and see if she has any suggestions on that. It'll be a separate red cap form, Heather. For our elective cases, is it appropriate to incorporate this frailty scoring as part of pre-admission testing? I think that would be fine. What do you think, Melinda, Catherine, on performing the frailty assessment?
I think that's probably the best time to do it.
Yeah, I think that's a
in a
great
very
idea.
Controlled, we could, think I need to address that with, more. It's about, some time frames when this can be done and where
Yeah,
this
we
can
don't-
be done.
We
and-
don't like the time frame of, oh, there's no time frame.
Yeah, I don't
We need
like
a
that.
time frame.
So I'm going to talk to him about that because
Yeah.
we have time frames for lots of things and people are used to time frames, and I think we need to. So I think that, we have that other measure where we do alcohol and smoking and all that screening, and we've got a pretty good time frame there. So I'm going to look at some other time frames and see if we can come up with something reasonable for this.
Yeah, I think that's a great idea. What expectation to also do the chair rises post-op? No, so you wouldn't have to do the chair rises post-op if it was an emergent case and they could not be done. You would just you would skip that and answer the. Hold
I'd
on.
like to answer the frailty questions, but not
Yeah.
do the chair raises.
And I figured out how to make it bigger. So hold
Perform
on.
the
Oh,
steps, the
dang it. He was so excited about adding in those videos and I couldn't play them successfully. I apologize for that. And we can add a little bar in here so you don't think this is the chair raised question. The frailty assessment will be, these questions, 1, 2, 3, 4, 5, 6 questions. And then this is the chair raised question here. The frailty assessment questions would need to be answered on those emergent cases, and you could fill that out post-operatively. The chair raises would need to be done pre-operatively. If it's an emergent patient, then you would just click unable to assess. Since this is mandatory, and then yes, thanks Judy on the threshold questions. So we will talk more about that with Dr. Weiler von Balmus and the other surgeon leaders here at STS to see what that's going to look like. This will not be implemented. I'm going to say this, I do not believe in that we'll implement a threshold for Harvest 1 2025. I think the threshold will be probably implemented when we start reporting this out in maybe a composite measure or as some type of outcome metric. So more to come on that, but I think that's going to be the what I suggest on that. And I think Melinda, Catherine, you probably agree. We don't want to just start collecting this data and throw a threshold out there. I think sites will need time, especially those that are still working to get this process built in. So
Yeah,
I would,
totally agree.
yeah, I would be
Yeah.
nervous with
Yeah.
just saying, hey, you have to
I mean, look how long it took us to get mortality thresholds.
yeah.
So,
So, and that's a very, very important outcome, right? And this is important too, but I think we have to, I mean, it's not going anywhere. So why not do it right and get sites up to speed and then
right.
implement a threshold when we see that most sites are going to start meeting that. We'll talk with the surgeons about it.
Yeah, I think that's a great idea.
For the additional beta blocker form for isolated cabbages, is this based on the procedure identification list or literally cabbage only? It's based on the procedure identification list. So you would include left atrial appendages, epicardial mazes, intracardiac mazes would be excluded, but it is based on the PROC ID chart. For NCDR, the process is different. If there's not specific frailty score documented, descriptive documentation can be used to capture. Yeah, it's different, Lucretia, and the surgeons decided to go this way with the questions instead of having the data manager try to determine the score. So can you please show the slide with the Epic Smart Phrase? I think, so what he did is he just went in to add an Epic Smart Phrase. He copied this form and then pasted it into the Smart Phrase builder, I guess. And then he labeled it frailty. So when he just typed in frailty into his report, it came up with the Smart Phrase. Oh, Hannah, hold on. Go ahead, Hannah.
Hi, thanks. The problem with copying and pasting, it will depend on the type of PDF you make accessible. Because I tried to do something similar with our Epic, and the PDF that was posted for something else, PDF was posted was not copyable. So particularly formatable, which is a big issue. So what is made available to us has to be accessible in that format. And it's a specific type of PDF.
Can you email me and let me know what type of PDF so I can post it in that format on the website?
I do know that sometimes you have to have the professional PDF maker. I forgot what it's called. Hold on.
Oh, the Adobe Pro.
Adobe Pro in order to do that.
That's what I use to. That's what I use to PDF the. That's the software I use. But if there's a special setting or something I need to turn on, just let me know and I'm
okay. I will find out exactly. I can't do it. I used to know, but they've upgraded the Adobe Pro, and I really haven't had time to learn all the ins and outs.
Yeah, no problem.
But if you post a Word version, Carol, it might be able to be typed. I've done that before.
Yes. Yes,
so
yes.
All the forms should be posted in Word. So if they should be posted in Word in the annotated, and you can unannotate them if you want to. So it should be posted in Word too for our data collection forms. If there's anything you need though, if anybody needs anything different, let us know, because we can, we can send you whatever version. whatever version you need. Thanks. Okay, I know we're way over time and I want to be respectful. I'm sorry that we didn't get to all the questions. There's still 101 sitting there. So, but we will meet again. We have a meeting next week on February 13th at 3 p.m. Central Time. We're going to talk about harvest close and go over the executive summary that will be updated to show real-time data. That functionality is being added in this weekend. And then, so we'll have a webinar next Tuesday to go over that. And then we also have a webinar the following week for, it's the quality series, but instead of focusing on ventilation times this month, we're going to be talking about the beta blocker data collection form. And we can also follow up on some of these questions we were not able to get through. I'll invite Dr. Moritz Weiler von Balmus back probably in March, maybe March or the monthly webinar in April. We can touch base again with him and make sure we're all prepared going forward to start collecting this data successfully. So thank you, Melinda. Thanks, Catherine. Thanks, Leanne. Thank you, Heather, Hannah, and everybody that came on today. And of course, thank you to Dr. Weiler von Balmus for joining us, even though he's already gone. So I'm sorry I couldn't get to your question. Thanks, everybody. And have a great rest of the day.